So in terms of myself, I got a phone call asking me to be doctor for Limerick in 2012, and I suppose I'm sure many people in the room who was fortunate enough to be able to call Dr. Con both a friend and a mentor. And I'd say Con was the first person I rang after I got the phone call. I said, just hang on a minute, I talked to Con, and I said, Con, what do you think? He said, oh, you'll do it all right, and you'll enjoy it. And showing both our age now, Con said, you'll be like the best ESB meter reader in the country. You'll be collecting numbers all over the shop. He said, every orthopaedic surgeon you meet, every radiologist, everybody that you meet, you'll collect their number and you'll talk to them, every physio. And that has, of course, proved to be the case. It's a thing that, Erska, Kayla, Warren, Nadine, we all help each other out in this. And I suppose the other evening in Limerick, I was speaking about chronic injuries and I suppose sportsmen's groin, and there's plenty of different names for this particular condition, I suppose, is a chronic condition in general that, again, in my personal experience, has evolved over time. So, as you probably know, the term Gilmore's groin was first described in 1980 by a surgeon in London, Jerry Gilmore, who treated a Tottenham Hotspur professional footballer for a chronic groin injury. And it's kind of evolved over the years. In my own personal experience, I've seen very little of it, I have to say, in the last number of years. So about 10, 12 years ago, when kind of my playing career overlapped with becoming team doctor, you'd have heard a lot of it. I don't see it anymore. I'm not sure if any of you do much. In the last 4 or 5 years, I think I've referred 3 people to a surgeon for this. 2 were rugby players from Rough, a fullback, and an out half who ended up having a surgical repair, and 1 hurler who was treated conservatively and did fine coming back. I suppose in terms of the literature that's out there and definitions, nomenclature, etc., the British Hernia Society, which unfortunately I'm not a member of, I feel very left out of that, but anyway, the British Hernia Society released a consensus in 2014, outlining, I suppose, the definitions and diagnosis as well as potential treatments for a sportsman's hernia. And I suppose the nomenclature that they came up with was inguinal disruption, which I suppose accurately describes what you're dealing with here, though I do have another definition coming up in a few minutes of it. But anyway, so again, I suppose the definition per se is pain, either insidious or acute onset, which occurs predominantly in the groin area near the pubic tubercle, and there's no other obvious pathology such as a hernia to explain their symptoms. And again, can't emphasise enough, as we have in other conditions already today, the careful history and examination is the most important thing to outrule other conditions such as we've heard, FAI, pubic symphysitis, etc. And basically, you've got an abnormal tension in the inguinal canal due to varying degrees of disruption. And it was decided at this consensus conference that if you 3 of the following 5 clinical signs, you could give a diagnosis of sportsman's groin or inguinal disruption. So pinpoint tenderness over the pubic tubercle, palpable tenderness over the deep inguinal ring, pain or dilatation of the external ring with no hernia palpable, pain at the origin of the adductor longus tendon, or dull diffuse pain in the groin, often radiating across the midline. I suppose here's an anatomical picture of same. Again, I think somebody else earlier today said everyone should take home one message from each of these presentations. So again, if I was taking home a message from this today, I'd look at the surgical picture here on the bottom right of the picture as you look at it, and you'll note that there's a blue line there that's called the genital branch of the genitofemoral nerve. Now, I don't know a huge amount about anatomy or nerves, but I think my take home message would be that if anyone was ever operating on my groin, I'd be looking up at them and I'd be saying, don't cut the blue line. Simple as. So again, MacGyver stuff. Anybody open your groin? Don't cut the blue line. Okay. Next. So anyway, look enough, we've got Kieran here at the top. So in terms of imaging, sure everyone gets an MRI now anyway. Players decide this themselves, I'll have an MRI there, doc. Of course you will. Where do you want it? Here. So sorry Kieran, that's generally the way it goes, as you know, and I suppose the best thing we can do again. Patient-driven, and it tends to be, unfortunately nowadays, patient-driven or younger players, mother-driven or father-driven or whatever. One way or another, patients are getting more imaging, and I suppose, again, I'm sure that you would be glad if I emphasise that we do need to provide proper clinical information on our requests. But anyway, I suppose MRI of groin is taken to be the gold standard of imaging, if that's fair to say. And again, in the younger patient, what tends to be seen is diffuse bilateral edema, and the athletes over the age of 18, it's generally subcortical bone asymmetrical changes. I suppose I should add that this is generally of male athletes, so the sportsman's groin or inguinal disruption tends to be in male athletes in kicking sports. Maybe you see more in Gaelic football, but I see very little of it anyway, and it would be rugby guys that I would have come across where you get this mostly. So you don't tend to get it in the cyclists, the swimmers, etc. In terms of management, so again, it's mostly conservative, thankfully. And again, with the evolving nature, I think, of sports, so with pre-season screening, with strength and conditioning, good physiotherapy, etc., I think we're seeing less of this condition. I think people are being picked up early when they're getting, what we would have called in the old days groin strains, and they're being screened out, and this tends not to progress. So again, in the first 1 to 2 months, it's prehabilitation, it's strengthening up the area. If this drags on more than 2 months, you might consider referring for surgical management. In the interest of time, and I'm not a physiotherapist, so I'm not going to go over the different prehabilitation and rehabilitation post-surgery aspects. But again, I suppose the efficacy is same, can't be emphasised enough. And again, there's generally pre or post-surgery. There's generally a kind of a 5-week prehab or rehabilitation procedure, and the general time back to play after diagnosis of the sportsman's groin is generally somewhere between 1 and 3 months, depending on the severity of same. Again, surgery required in about 60% of patients who have symptoms continuing after 2 months, and the role of surgery is to release any abnormal tension in the inguinal canal. There's different types of surgery. There was a recent paper in the British Journal of Surgery looking at open repairs versus extraperitoneal repairs. Basically, it showed that they were both very effective, so greater than 90% of players return to play within 3 months, and there doesn't seem to be a huge difference other than that the extraperitoneal repairs cause less pain in the first month post-recovery. So the surgery is quite effective. Now, the Yanks, great people that they are, have their own name for this called athletic pubalgia, which is great, I think. I mean, it's obviously an awful lot better. I mean, you're inside there in the medical room and the manager comes in. What's wrong with him? Gilmore's groin. My bollocks. What's wrong with him? Athletic pubalgia. Carry on. So I like this athletic pubalgia. I think I'm going to go with that from now on. Athletic pubalgia. So, and again, I suppose, going back to our consensus, again, they're saying surgery is only a final treatment for athletic pubalgia, and when a non-surgical treatment fails, and even that is controversial. And again, I quote them, given the money and popularity of the NFL, it was important to understand surgical outcomes. So they looked matching age and for age and level of players who got surgery for athletic pubalgia versus players who had no similar injury but were at that level. So again, I suppose the striking things for me was the average career length in the NFL is 6 years for guys who make the opening day of season and the rookie season, but in general 3.3 years for all NFL players, which I didn't realise their careers are that short. But anyway, bottom line, 90% return to a sports rate after surgery, and there was no significant difference in their post-operative performance, but players did tend to play less games per season than players who did not have an athletic pubalgia injury beforehand. There are other treatment options, such as steroid injections for pain relief, anti-inflammatory. There's been a paper describing radiofrequency denervation of the inguinal ligament. But again, they're generally adjuncts to prehabilitation. And again, I suppose, as I'd mentioned the other night, there's a misconception out there by certain journalists that the team doctor goes around with a bag of drugs and just hands them out on the team bus. And I think that's certainly not the case in my experience. And we all need to be aware that, certain medications will predispose players to injuries, such as acute kidney injury. We've had mutual experiences the same. So diclofenac, diphenol, or diclac being another trade name of it, being, I suppose, the most common one in terms of causing acute kidney injury. So I'll conclude that because my time is up. Again, for me, in the evolution of things, I'm seeing an awful lot less of athletic pubalgia or inguinal disruption, if you like. Again, history and exam is the most important thing. Consider other diagnoses. Look for your 3 of the 5 clinical signs, but again, it's multidisciplinary. Physiotherapy involved early. Surgical outcomes are good, but generally that's only if conservative management fails after 2 months, and return to play generally 1 to 3 months. Thanks very much for your attention.